Hello and happy Teach Me Tuesday. My name is Lisa Houston and I am a NICU nurse educator. I am here to bring you NICU education for NICU nurses. We have entered the month of February, which is Heart Month. We do all these things about hearts and love and all that. And so our month of February is going to be a month where we talk about hearts in different ways. And we're also going to kind of do it similar to our January where we did back to basics with assessment. And we're going to do a little bit of back to basics with cardiac, and we're going to cover medications, different cardiac anomalies. We're also going to do intro to extrauterine transition, lots of fun things during this month of February where we can kind of break it down and help all NICU nurses from novice to expert. So keeping that in mind, we split this up into two. So we're going to have a video today, Tuesday, and later this week on Thursday. If you are following me on Instagram, maybe you participated in the poll. Did we want one long set of slides where we review maybe 13 or 14 medications, or should we break it up into two? And you voted and said we should break it up. So today, for this Teach Me Tuesday, for the first week of February, we're going to cover blood pressure medications. And then on Thursday, we're going to cover other common medications we use in the NICU. And you're going to see a little bit of overlap because the parent education we'll talk about today, but not Thursday. So let's review. Cardiac medications are crucial for NICU nurses, and sometimes people don't think that in regards to, are we going to be using all these meds if I work at a level 3 or even a level 2? But as we all know, a baby could turn at any time, so having a basic understanding of them is super important. If you work at a level 3, maybe you don't keep cardiac babies for long, but you might need to start medications for them. So we need to know which medications are supporting heart function, which are regulating blood pressure, which ones are specific for a certain disease type, and what they're exactly influencing. When we get to the epinephrine slide, I'm going to tell you an interesting story that really impacted my life as a NICU nurse. But because every baby is so different, which is going to be part of the epi story, we really need to understand each medication. So when we're talking about blood pressure, dopamine seems to be our first line of defense, right? It's the first medication we go to when our blood pressure is low. If you remember last week when we talked about other assessment parts for NICU babies, we talked about blood pressure and how we want their MAP to be close to their current gestational age. There's a lot of information out there that maybe it doesn't need to be exactly the same if the baby is still peeing, if their perfusion is good, if they're waking up, they've got good electrolytes, etc. But if at any time those change, or if the blood pressure is just too low, or they're new and we're not giving them a ton of fluids, dopamine would be our first line. It goes on to the alpha adrenergic effects to get vasoconstriction. Dopamine has a lot to do with peripheral vasoconstriction. So that really means that we're saying to the periphery, hey, you don't need blood as much. We need to get blood to the core. So let's constrict out here, right, away, and send that blood to the heart. We know that our blood pressure is our cardiac output, is a heart rate times stroke volume. So can we make that stroke volume bigger by sending more blood to the heart? We typically do this in doses of 5 to 20 micrograms per kilogram per minute. It's very important to think about this dosing range, because if you're on 15 mics and your baby is still having a bad blood pressure, we need to be thinking about what else could we add. So typically dopamine is used in sepsis and hypotension, as we discussed. It increases the contractility of the heart. It does increase the heart rate, but primarily it is going to increase that SVR and the PVR. So think about that vasoconstriction. Pulmonary vascular resistance, right? Systemic vascular resistance. What can we do to get more blood to the heart? I use this as an example, and I think it works here in this part of this slide, as to a hummingbird's heart rate and an elephant's heart rate. Right? Their heart rates are very different. A hummingbird's heart rate is very fast because their hearts are so small. The amount of blood they pump each beat is very small. So their cardiac output is small. Their stroke volume is low, so they need to keep their heart rate higher to get that cardiac output high. Whereas an elephant has a bigger heart, and so when it pushes out of their heart, it is going with a larger stroke volume, right? It's saying, hey, let's squeeze more out each time. So when that happens, the heart rate doesn't need to beat as fast to keep the cardiac output high. So that's the same thing here. We're trying to make it so that we can get that heartbeat in the heart more efficiently moving by affecting the stroke volume and getting more blood to the heart. So thinking about that pumper, that left ventricle, how can we make it pump more blood out the stroke volume per beat? So again, we don't need this idea of, do I know my alphas and my betas receptors? If you're a novice nurse, if you're a 21-year experienced NICU nurse, you may still have confusion over what is alpha and beta receptors. And that's okay. No one's standing at the bedside grilling you on this. If you work in a cardiac ICU, they might be, okay? Shout out to all of you. You're amazing. But I say this in the mechanism of action is so that you understand that this is why you might be running both meds at the same time, because they have different receptors and different effects. So with the dopamine, we talked about our cardiac output is heart rate times stroke volume. So we're kind of fixing that stroke volume with our peripheral vasoconstriction. But with our dobutamine, we're making that pumping, that myocardial contractility more efficient so that our cardiac output is better. Dose is the same, 5 to 20. These are typical dosing ranges. I am going to tell you on dopamine, I have seen it used lower than 5 when we're just giving like a little renal stimulation so that the baby will pee. So it can be used for that. But we use with hypotension, HIE babies, and of course those with ventricular dysfunction. Looking on here, right? We're going to improve our contractility, but we're definitely going to improve our heart rate. So if we put dobutamine and dopamine together, we have fixed both sides of the cardiac output equation, which is stroke volume times heart rate. So this does not want to go to my next slide. Let's see if we can figure this. Sorry for that technical 10 seconds of reality. So here we are at epinephrine. So epinephrine is going to work on both your alpha and beta receptors. The big thing I really want to talk about with epinephrine is contractility. So my story is we had these small babies, these 24-week twins that were born. They were both on a little bit of blood pressure medication, but one was not doing as well as the other. And he was on increasing doses of dopamine, and we did an echo, and the cardiologist was at the bedside. And as he's standing there, he's saying, look at the left ventricle. The left ventricle is not contracting well. It's not so much that we need to get more blood to the heart, or we need to give more products, or we need to give more saline and give a blood transfusion. It's that we need to fix how the left ventricle is functioning. So we actually stopped our dopamine and put the baby on epinephrine, and their blood pressure came up, because we fixed the contractility. So it's a big thing to think of here. We also know that epinephrine, which is, it causes that rushing, right? Any of us have ever had our adrenaline rush, or maybe you have an allergy and you've received epinephrine. It also does cause vasoconstriction, so it's going to get blood up there, but primarily it is going to focus on that contractility. I also want to remind you that here with my education resources, we do talk about what happens most of the time. So this dosing range I think is amazing, but I've definitely used doses outside of here in urgent situations where we did not really have anything else to do. So remember, we talk about the 90% of the time. There's going to be outliers on both ends with everything we talk about here in our Teach Me Tuesdays. So just keeping that in mind. You're going to see epinephrine used in severe heart dysfunction, hypotension, HIE babies. I've seen it on really sick meconium aspiration before. So those are the kinds of babies that we would see this on. Hydrocortisone is not used usually as an immediate drug like epi or dobutamine would be used. It's more of a stabilizing blood pressure medication, or how we get babies off of those potent IV drips. And it's in more of an intermittent dose. It's given IV every 6 to 8 hours. It can be used in adrenal insufficiency. It can be used with shock. This is going to be something that they're going to be on for a few days. You may also see hydrocortisone used in other instances, but primarily it's really helping to kind of stabilize that blood pressure. So the difference between epi, dopa, dobutamine is that they are continuous infusions, whereas hydrocortisone is more of an intermittent medication used kind of as a weaning. Those are the 4 you're probably going to see the most as a NICU nurse. Absolutely, there's going to be more. We're going to talk about vasopressin real quick. Vasopressin is something that I've seen used more recently. I for sure did not hear this medication 10 years ago, but we also did not keep our really sick babies, or if they need ECMO or anything like that, in the unit I worked in at my first job. So just something to think about. Vasopressin is new I love saying new. As we talked about before, there is so much to the NICU that is young and new. We are a young disease. NICU really has only been open and around for 45 years when you think about med surg in comparison. So this really is about your vascular tone. It's about vasoconstriction. It's about making your vasculature work better. These are your typical doses, and it's obviously used with hypotension and with shock. It does have a max usage time. I saw that in a few places, and most of the evidence I was reading was 72 hours. So I thought that was interesting. So I just wanted to bring that up. Make sure that you are reading your instructions for use, your IFU. That's what I couldn't remember on Instagram this weekend. IFU, instructions for use. Make sure you're checking with your pharmacy for compatibilities. Vasopressin has some incompatibilities. Make sure it's going to keep your line safe. All of those are things you should do all the time, but especially for this, which is not as common of a medication. As I mentioned with this two-split education, we're going to talk about parent education today, but we will not talk about it on Thursday. So come back here on Thursday if you want to review this. But really thinking about our parents in these situations, and this is, if we're talking about dopa, dobutamine, epi, vasopressin, hydrochlor, all those things, their baby's probably unstable, right? And so they're going to be in this high stress environment. They're going to be asking a lot of questions. They're probably not going to be retaining information well. Additionally, their bonding may be affected because they can't hold. Maybe we're trying to get in specialized lines for the infant. There's a lot going on here. So what can we do to reassure them? And a lot of that's going to be having answers to these questions. So why is my baby receiving a cardiac medication? This is going to be true for anything we review on Thursday as well. So some medications help the heart pump better, others improve blood flow. We choose them based on their condition. What are we monitoring? We're watching their heart rate. We're watching their blood pressure. We're doing echoes, right? Like I mentioned with that epinephrine baby, we're doing echoes to make sure that what we're doing is having the right effect at all times. When should I be concerned? If your baby's heart rate's too low, if your baby's heart rate's too high, if you're seeing drastic changes in either of those directions or even on the blood pressure, if the baby has changes in their color, those are things we're going to look for. And how can I be involved to be there for rounds, doing your baby's cares, doing oral care for your baby, providing milk for your baby, changing the diaper, giving them something to lay on that smells like you. All of that is going to be super helpful, especially in this changed bonding time. I always have a tricky, pulls at my heart when a baby has been kind of steady or doing well and the mom and dad have been holding every day, and then all of a sudden the baby's not doing great and we've had to make some changes, or we've had to put a PICC line back in, or something's going on. It's like that whole idea that you take 2 steps forward, 1 step back really applies to the NICU, and why we call it a roller coaster. So to recap this section, we really are just talking about these medications that increase our blood pressure, right? Dopamine increases blood pressure by getting onto your receptors, causing that contractility or your stroke volume to change. Dobutamine enhances contractility. Epinephrine is a potent vasopressor. We're going to talk about inotropes as a bonus on Instagram this weekend, so please join us there. Knowing when and why to use your medication ensures your proper treatment of this hypotension. So as NICU nurses, it's really important for us to recognize, hey, this is what's going on with the baby. This is what I need to do to fix this. I've noticed that we've been on this medication and we're at 15. We can only go to 20. What would we do next? When's our last echo? What does our x-ray look like? To help put this whole picture together. So I will see you on Thursday for part 2 of cardiac medications. Please reach out to me if you have any questions. Make sure you're following me on Instagram for all of the latest updates. Have a great Tuesday.